Welcome to our substance abuse lesson. The purpose of this video is to provide you with a real-world nursing education that goes beyond just this nurse workbook alone. So in this video, we're going to talk about substance abuse, but we also want to talk about ingestions as well and what are potential antidotes to ingestions. And the thing about ingestions or overdoses is that they're not always intentional. We can have them be very unintentional. So maybe a child breaks into a medicine cabinet and takes some of these pills. We could also have our elderly that maybe get a little confused and they're taking more tabs than they should be because they don't have good monitoring going on when it comes to taking their medicines as well. Maybe also some people put certain pills in different bottles and they might not be labeled correctly. So it's important that we know what antidotes we can give if these situations arise. So first, we're going to talk about Tylenol. And most of the time, these are unfortunately not accidental ingestions, although that can also occur. But when a Tylenol ingestion is large enough, then this does require an antidote. And this is one of the more common things we can see in our kids whenever they're having an ingestion present. Oftentimes too, kids don't know how dangerous Tylenol can actually be, so they can take a little bit and thankfully be in a safer zone, or they can take a whole lot that can be very dangerous. When we see Tylenol overdoses or ingestions, we're going to be giving this stuff called mucomist or this acetylcysteine. And there's a specific way that we're going to give this antidote, and we call this the 21-hour protocol. Thankfully, we can draw a Tylenol level in our blood serum, so we can figure out how much of a Tylenol ingestion has actually occurred. The problem is that there is Tylenol that's an extended release dosing. So sometimes it can take more time or hours to actually get our real Tylenol level because it's still waiting on that extended release. However, if we do see that it's elevated enough, we're going to go to this protocol. So our first dose of our acetylcysteine is going to be our loading dose. We're also going to follow the loading dose by a second maintenance dose, and then we'll have a third maintenance dose. So what is the point of these three doses? Well, first one on our loading, we're going to give this over the first hour, and this is going to rapidly establish a protective level of glutathione in the liver. So this is going to help metabolize that Tylenol and break it down. So we want to make sure that we build this level up so our body is able to process it. And our second maintenance dose is going to be given over the next 4 hours to sustain the replenishment of the glutathione. And our third maintenance dose will be spread over the final 16 hours to ensure a continued supply of glutathione for the detoxification process. Since this video is geared for real-world nursing education, I will tell you this. There are some places that they've talked about the importance of making sure that you have your bag ready when the one wears out. Now, of course, a minute or two can pass, but when we have someone with a very high Tylenol ingestion, we want to make sure that those bags were really on top of. So one tip or trick I can tell you is before your loading dose is up, 10 to 15 minutes before, set your pump for that time frame. So it's going to alarm you that it's almost up instead of allowing this medication to fully run out. Now you can notify the pharmacy, although pharmacy is typically on top of stuff like this, and then you're able to have your next bag prepped. And this goes for any kind of medication you're going to be giving through an IV. And for our benzodiazepine overdoses, we can give an antidote known as romazicon, and this is going to be a benzo receptor agonist. So it's going to quickly inhibit the action of our benzos at the GABA receptor that can effectively reverse the central nervous system depression. So this is going to help bring our patient out of that sedative state. And a lot of us might already know our opioid antidote, and this is going to be that Narcan or naloxone. So Narcan is going to kick off the opiate that's sitting on the receptor, and it's going to bind to it. The only problem is that if we have a lot of opiate ingested in our patient, then we might need to give that Narcan in another 30 to 90 minutes. because when the Narcan binds to kick off and replace that opiate, it's going to wear off within that 30 to 90. So if we still have opiate floating in the bloodstream, the opiate will rebind back to the receptor. But if we give that second dose of Narcan, this will continue to keep that opioid kicked off the receptor until the body has metabolized it. So if our patient needs even more, we can do a Narcan drip, and we can always titrate that too. So we don't want to always throw our patient into a full-blown withdrawal. And so we can titrate back on the Narcan a little bit to keep them in a nice state where we're definitely keeping their respirations going, we're keeping our patients safe, but we're not kicking them into full-blown withdrawal. And if we have too much beta blockers, this can lead to severe bradycardia and hypotension, and this could be fatal. So we can give glucagon, since this can help block the effects of adrenaline on the heart and blood vessels and avoid the bradycardia and hypotension. And if we have too much calcium channel blockers, this can also be life-threatening because of the severe hypotension, bradycardia, and potential cardiogenic shock. So to combat this, we can give calcium salts such as our calcium chloride or our calcium gluconate. And this is going to put more calcium into the bloodstream. So these calcium channels are being blocked. But if we throw more calcium in there, then hopefully we can make it where this avoids these complications. And this brings us into one of the most important conditions we got to talk about when it comes to being at the bedside. And this is going to be our alcohol withdrawal. And this is a potentially life-threatening response to a lack of alcohol. Consumption in chronic abusers can vary its onset from hours to days. And this is a really important subject to me because oftentimes I think that at the bedside, this can be very undertreated. And I think a part of this is because it can be really easily mischaracterized. When we have our chronic alcoholics that come in, they're not in their right mind. Additionally, they're a really poor historian to their own symptoms, and they also can lay there and fall asleep and pass out. And there's absolutely no problem with them sleeping while they're there. But we don't always realize how much withdrawal symptoms can be occurring until they wake up, and it could be potentially be too late. So when these patients wake up and they start having full-blown tremors, maybe hallucinations and everything else, we're already behind the game because this can be detrimental to their neurological system. So this brings us into the types of medications we can give for this alcohol withdrawal symptoms. So if our patients start to have hallucinations, delirium, agitation, we can revert to our antipsychotics. And this is going to be that Seroquel or Haldol. So these drugs can temporarily get our patients through the moment. But there are two things to remember whenever it comes to these antipsychotics. These medications can actually cause something called prolonged QT syndrome. So before we give them, there's something very important that we want to do. We want to make sure that we take an initial EKG when giving antipsychotics because prolonged QT can lead to that cardiac arrhythm known as torsades de poids. And this means twisting of peaks. And we talk all about this in our cardiac arrhythmia lesson. So if our patients have an underlying prolonged QT as it already is, giving them a medication like this can make it even longer, which could cause them to go into this cardiac arrhythmia, torsades de poids. So we always want to take that initial one before we give this medication. In addition, alcohol withdrawal can also lead people into seizures, and we're going to get into that in just a minute. But these antipsychotics can also lower our seizure threshold. So we also want to be cautious that we're giving these also as needed. And next, we're going to want to replace our dehydration. So we're going to have IV fluids with our electrolytes. This is especially going to be the magnesium, our phosphate, our potassium, and plus multivitamin replacements such as our thiamine. So this is also multiple pieces, just as something that sounds so simple. So thiamine, we're going to get into in just a minute because of a detrimental effect that a lack of thiamine can cause for people. But if we think about alcohol in itself, it is a diuretic. So it's going to make people that chronically abuse alcohol have a lot of urinary excretion, and electrolytes are going to come out of our urine. In addition, a lot of people that are heavy drinkers do not have great nutritional intake. So we're going to want to make sure that we replace a lot of these electrolytes to keep them safe when it comes to that aspect. We're also going to want to manage that dehydration, and we'll talk about our thiamine in just a minute. We can also give a maintenance anti-withdrawal medication, and this is known as that Delirium. And then we can give our anti-seizure medication, and this can be prophylactic or it can also be as needed. So all of these interventions that we can do to manage these withdrawal symptoms are all going to depend on what stage of withdrawal our patient is at, because not all of our ETOH withdrawal patients are going to be the same. There's so many factors that can come into play. Is this patient a very long-term chronic drinker? Did they just go on a 5-day bender? Is this something that they've gone through before where they have already had seizures from their withdrawal? There's a lot of potential outliers, so what we choose to give is all going to be very patient-specific. But two of the most important drugs that are the gold standards for our acute alcohol withdrawal is going to be our Ativan and our Valium. So these are both benzodiazepines, and this is going to help slow down a lot of the neurological activity that can go on from this alcohol withdrawal. So how do we gauge what we should be giving and how much of this benzo should we give? And these medications are going to be dosed at what score? Well, this is that CWA score. So the CWA, or our CWA-AR, is a more revised version, and this is going to be specific to your facility. So not every single CWA score is going to be, or CWA template is going to be the same. But this can measure 10 alcohol withdrawal symptoms. And this is going to include our patient's level of agitation, anxiety, auditory disturbances, are they hearing things, headaches, clouding of their sensory, nausea and vomiting, paroxysmal sweats or that diaphoresis, tactile disturbances, tremors, and visual disturbances. So when we're scoring our patient, we're going to rate them by a point system. And this is going to be from 0, which is no symptoms or mild symptoms, where 7 is going to be our severe. And again, this can be hospital specific. Some of these can score up to 10 points. Some of them can be 5 points, but this is just a baseline example of a CWA score. So we're going to go through each one and tally up what our patient ranks. We'll ask them questions. We'll do a whole bunch of testing to gauge their direct CWA score. So this patient, for example, is going to have a 24. So coming back to our activity here, this CWA score is a 10-part scale to measure the severity of their withdrawal. A 1 to 9 would be classified as a mild withdrawal. A 10 to 19 would be a moderate withdrawal, and anything above a 20 would be high. So our patient that we just scored would be high because they scored a 24. So there are two conditions that can happen if our alcohol withdrawal is severe enough. And this goes back to that thiamine that I said we are going to circle back to. So there's a condition called Wernicke's encephalopathy. So this is going to be a brain disorder that's caused by a lack of vitamin B1, also known as our thiamine. Alcohol makes it hard to absorb this vitamin, and this can happen to people even with poor diets and not necessarily just alcohol abuse, but they might also just have a hard time absorbing this nutrient. This can lead to serious brain and nerve problems without the right vitamins. And our symptoms of this is going to include confusion, balance, and coordination problems. So when we have our patients with alcohol withdrawal, or even with not, and there's any indication that this is present, we are always going to expect multivitamins, vitamin B1, or that thiamine to be on board that we're going to give our patient. Our next condition is known as delirium tremens. So this can also be severe and potentially life-threatening, and this can occur in people who have been heavily drinking for a long time and suddenly stop or significantly reduce their intake. In most severe cases, this slows down the neurons and enhances GABA that inhibits brain activity. And this leads to that rapid overexcitement in the brain's neurons and it induces seizures. So here is why it is so unsafe to allow our patients to get to this level of withdrawal. So when we are having these patients and we might see an initial dose of Ativan ordered or some Valium, that does not mean that our job is over because we gave them a little bit of medication. If we go to check back on our patient even in 5 minutes and it seems like things still are not working or helping, we can reevaluate by doing another CWA score. So our CWA score is never going to be per hour or per 15 minutes. This is something that's going to be always evolving as our patient's status is as well. There are times that our patients can have such a severe withdrawal that they're going to require a severe or so much amount of benzos in them that you would feel almost weird giving them how much benzos that they possibly need. It will feel not right to see somebody getting that much. But this is a kind of red flag in your brain that this is the type of patient that needs to be in the ICU. They need to be on a benzo drip, maybe an Ativan drip or a Valium drip, so that way we can calm everything down and avoid this delirium tremens or any kind of cerebral edema that can be caused from their seizures that they could potentially be induced into. And this concludes our substance abuse lesson. I'll see you in the next one.